We are set to start our second half of our review course for today. Are we ready?
We are ready and we are live now.
Yeah, okay. Are we in contact with Dr. Lou Bridges? Is he online?
Yes, I'm here.
Yeah, hi Lou, how are you?
Good, how are you?
Yeah, we are pleased and honored by your contribution. Thank you very much for accepting our invitation. Lou Bridges is the head or chief of New York Hospital for Special Surgery, Cornell University, New York, in the USA. This hospital is considered in this position the highest clinical post in the field of clinical rheumatology in the USA. I have known Lou for 32 years since I had my sabbatical at the UAB in the USA, and he has been very active in research, and he presided over the UAB for a while, for some time, for many years, and he pushed it higher and higher, and now he's the chief of New York Hospital for Special Surgery, and he has a lot of research. He's very prolific in his research activities, and he turned the UAB into a hothouse for producing research in many aspects, especially RA. He will talk to us about the current management and prospective therapies, and I think he's the best to present this topic to us. Thank you very much, and the platform is yours, Lou.
Thank you so much. It's my privilege and honor to speak today. Dr. Ragab, it's great to see you, and I'm glad to renew our friendship virtually after 32 years of knowing each other, so thank you very much. So today I'm going to speak to you about current management and prospective therapies for rheumatoid arthritis. Next slide, please. So what I'm going to do is give you first a very brief overview of the current medications that we use to treat rheumatoid arthritis. Then I'll talk to you about some prospective new biological DMARDs and targeted synthetic DMARDs very briefly. And I'll spend most of the time on talking to you about innovative approaches to improve management of RA through big data and machine learning. So the second bullet point there, I think, will be very microscopic, and that we will look at pathogenetic pathways and new drugs very briefly. And the third bullet point will be more looking outward in terms of what can we do to use the drugs that we currently have in a better fashion to treat our patients with rheumatoid arthritis. Next slide, please. So this slide lists the current medications used to treat rheumatoid arthritis, and I have gold salts under conventional synthetic DMARDs, even though it was a heavy metal, and we don't use it anymore, but it was a staple when I was a fellow in training, which dates me. So we don't really use much azathioprine, but you can see on this list methotrexate, which remains our anchor drug, sulfasalazine, hydroxychloroquine, and leflunomide. Under the targeted synthetic DMARDs, we have 3 Janus kinase inhibitors, tofacitinib, baricitinib, and upadacitinib. Of course, we have corticosteroids and NSAIDs. And then if you look on the column on the right, we have biologic DMARDs, including 5 FDA-approved TNF inhibitors, an IL-1 receptor antagonist, anakinra. We have a drug that targets T cells, abatacept, one that targets B cells, rituximab. We have 2 that target IL-6, tocilizumab and sarilumab. And then, of course, we have now a variety of biosimilars that vary country by country. The next slide, please. So this is a very nice slide from Professor Ian McInnes and George Shett that was in the Lancet a few years ago. And if you look at this slide, the boxes that are in kind of pink are really the pathological steps in the development of RA. So if you start at the top, you can see the genetic factors. interplay with environmental triggers such as smoking, periodontitis, etc. There are protein modifications, which include citrullination, carbamylation, and acetylation. There's then a first hit where you have an antigen presented to T cells, B cells that then lead to an inflammatory pathway of T cell activation and B cell activation. And so what you can see there is in the darker boxes, we have existing treatments, and the lighter boxes, treatments in development. So if you go back to environmental triggers, smoking cessation is one. It's not exactly a treatment, but it is an approach to try to reduce the incidence of rheumatoid arthritis. When you have the first hit, you then have T cell activation, and we do have two drugs that affect that pathway, as I mentioned earlier, abatacept and also JAK inhibitors. And then you have novel approaches to inhibit the T cell activation through the use of Tregs. When you look at the B cell box, we have an existing therapy, rituximab, but there are also, and I'll talk very briefly, other kinase inhibitors that may influence B cells that are under development. And then when you see on the bottom half of the screen, the second hit, there is, it seems to be then that's when you start to really trigger the development of the clinical manifestations that we see. And these involve autoantibodies, as you can see, and synovial inflammation. And again, going down, you can see that we have abatacept and rituximab that seem to inhibit autoantibodies among other pathways. But then there are also IL-23 inhibitors that may be that are under development that may be used early in disease. You then see synovial inflammation, and if you see the treatments that are currently existing, TNF inhibitors, IL-6 ligand and receptor inhibitors, and JAK inhibitors, and there are GM-CSF inhibitors that may play a role at this stage on macrophages and neutrophils. And then on the right, you see what we all commonly recognize as clinical rheumatoid arthritis, which manifests as synovial hyperplasia that involves fibroblasts and multiple molecules there, osteoclasts that include rank ligand, TNF, etc. And then we have associated systemic findings in rheumatoid arthritis, such as atherosclerosis, abnormal liver function there, the CNS, the pain and depression, and you can see the mediators on the right there. So if you look at the next slide, this is another view, but at much more of a microscopic cellular level. And you can see here represented these pathways, and this is from a little bit older paper from Dr. McInnes and Dr. Shedd, but you can see the cell types and the molecules that are involved in the processes shown here. And then next slide, please. So now you can see that some of the targets I alluded to earlier are FDA-approved medications. So you can see that the red arrows show that we have drugs that inhibit the T cells, the B cells, interleukin-1, TNF, and IL-6. Next slide, please. So this is a different graphic representation of, in many ways, the same thing. But what you see here is in green are the currently approved drugs for use in rheumatoid arthritis, and in blue, drugs in development. This is from a different group in a more recent review, but you can see there that in the blue boxes, what I've highlighted is if you look at TNF at the top, we have 5 TNF inhibitors, but there are others under development. The numbers there represent, after the drugs, represent the phase of development. If you go then to the left, you can see that there are some drugs like Decavil, which is under development, that has a vascular targeting antibody, F8, fused to an IL-10 protein that's under development. If you look at the T cells and the IL-6 receptor, there are new monoclonal antibodies to the IL-6 receptor that are under development. as well as drugs that target IL-6 itself, and you can see those listed there. And then I mentioned briefly a couple of novel targets, GM-CSF. There are 3 drugs, most notably mavrilimumab, which has been around for several years, and we've heard about its development, but I don't personally know where it is in the pipeline. But then we also have things that target novel molecules such as integrins that you see on the right, which are on the surface of fibroblasts-like synoviocytes, and then also chemokines such as CX3CL1. And so there, in addition to the current targets, we have several targets that are being for which drugs are being developed that may also be useful in the treatment of rheumatoid arthritis in the future. Next slide, please. So another microscopic level, you can see here BTK and the JAK kinase inhibitors. There's also a drug on the bottom right called, I'll mispronounce it, but iguratamode, which is under development, which may impact on the NF-kappa B signaling pathway. So in these few slides, I've shown that at the sort of the cellular molecular level, what the rationale for the current drugs that we have is. And I think there will always be room for some more drugs that will treat rheumatoid arthritis. But I think the next step in the evolution of how we better manage our patients is to really look at how we have management protocols, how we utilize the current drugs that we have, and how we can involve the patient in helping to improve their outcomes as well. So the next slide, please. So in the next few slides, I'm going to tell you about innovative approaches to improve management of RA, looking at a much bigger perspective, and that is big data and machine learning. Next slide, please. So what is big data? So big data is both structured and unstructured, meaning that in the electronic medical record, if you type something into a drop-down, use a drop-down menu, that's structured data. Unstructured is if you type free text into a box. But the definitions of big data vary. And in general, it's thought to be a field that looks at ways to analyze and extract information or deal with data sets that are too large and complex to be managed by one person or one computer. And this includes electronic health record data, administrative claims data in the US, such as from Medicare, and also large-scale genome-wide studies, transcriptomics, and many other omics approaches. Next slide. So why is big data important, and how big is the scale? You can see here it's really incredible that this is a little older slide. By 2020, it was expected that we would be having 985 exabytes of data. And you can see there that exabyte is 10 to the 18th bytes. So you have down below the bytes are you have byte, kilobyte, megabyte, gigabyte, terabyte, petabyte, exabyte, zettabyte, and I think eventually it'll be to the yottabyte stage eventually, because of the clinical data that we have in the electronic medical record, and the healthcare data can include radiographs, it can include many other images, pathological images. Patient-reported outcome data is growing, so we have a huge amount of data that can be a source of information for us to better improve patient care in RA. Next slide. So I'm going to walk you through, so the big data in healthcare can also include, as I mentioned, the correlation data, geo-environmental, clinical data, patient and consumer data, pharma data, and from many different sites, including disease-specific registries, and then administrative claims data for use of healthcare. Next slide. So big data, there's often referred to as 4 V's: volume, variety, velocity, veracity. There's also visualization and value. So you can see here that we're looking at a very broad level of what big data would be and how it might impact healthcare, and in particular rheumatoid arthritis. Next slide. So what is machine learning? It's a form of artificial intelligence, and it uses a computer to analyze data sets and organize them. And it could be used in several different ways. There's several different general approaches to machine learning. One is supervised machine learning. So for example, you have a specific question and you ask the computer to develop an algorithm to address that specific question. Another is unsupervised, and that is if you look at the huge amounts of data, let's say genomic data and the huge amounts of clinical data, such as a disease, a DAS score on a particular patient or response to a drug, and then you have huge data sets like genomics and transcriptomics, you can say to the computer, look in all these different sources of data and try to identify genomic clusters, for example, that influence treatment response to a particular drug. You can also use it from reinforcement point of view, where it can try to learn from its own mistakes and to improve. Next slide. So I'm going to show two examples of how big data and machine learning approaches are currently being researched to try to provide ways that we can improve the lives of our patients with rheumatoid arthritis. Next slide. So one is, which patients will develop severe erosive disease leading to joint destruction? Next slide. So the first step that we need to do this is we really need an easy, rapid, reliable way to quantify joint damage on hand and foot films. We will never be able to fully utilize the big data unless we can quantify the degree of damage. Next slide. So I recently had the privilege of working with a very strong group of collaborators. Next slide, please. And we put on what we call the RA2 Dream Challenge, automated scoring of radiographic joint damage. And it involved, this was when I was at UAB, it involved investigators at UAB that you can see there, but also at Mount Sinai. We were lucky to collaborate with Persio Golko, who is there, and Gustavo Stoloviski. And then you can see Jim Costello, and then we worked with a variety of very talented people at Sage Bionetworks that puts on many, many DREAM challenges. DREAM stands for Dialogue for Reverse Engineering Assessment and Methods. And we had financial sponsorship from the NIH National Center for Clinical Resources through the CD2H competition that they put in, and money from the BMS Foundation. Next slide. So this is the way that we currently score X-ray films for damage. We have visual inspection by an expert who looks at these target areas and scores on a basis of 1 to 5 or 1 to 4 in the hands and the feet, as you can see. This is the modified Sharp van der Heide method, and it is very much the gold standard these days. But to get these scores, you need to have someone who is well-trained to look at the score, look at the joints, interpret what they see, and then quantify it. Next slide. So what we tried to do in our challenge, next slide please, is what we did was we created a DREAM challenge to develop automated methods to quickly and accurately quantify the degree of RA-associated damage in the target joints of the hands and the feet. We had 3 sub-challenges. One was to look at the overall RA damage score, another to look at joint space narrowing, and a third to look at erosions. We provided teams with training sets, then a leaderboard set, and then a test set. So basically what they were able to do was to take images and scores that we had, train their algorithm, and then eventually we would give them a set of images for which we had the scores, but we tested them by having their computer algorithm come up with the closest to our gold standard, which was the Sharp van der Heide. And then we did have a small validation set afterwards. So why did teams collaborate, and why did they want to do this? We were lucky to have prize money. So we had $50,000 in prize money for the winning teams. Next slide, please. So we provided each of the participating groups with data on images and scores. You can see that we had access to 3 different cohorts. The first 2, clear and tetrad, were used in the leaderboard, in the training set, the leaderboard, and the test set. And for validation, we use some images and scores from TIER. And you can see the study design on the bottom, in which the teams got the training data. In the leaderboard round, they were able to give us their assessment of the damage on those films, and we told them how close they were and where they could improve. And then they had that iterative process. And in the final scoring round, we had a test data of 188 sets of films. Next slide, please. So I'm not going to go into this in detail, but this is the representation of the team. So there were 173 submissions from 26 teams from 7 countries in the leaderboard round. And in the final round, we had 13 submissions of people who worked very hard to try to address these challenges. And the 4 top performing teams were selected based on a set of rigorous standards. And then the robustness of the performance was assessed as well. So I'm not in an independent cohort from TIER. I'm not going to go through the details except to say that we enjoyed very much working with these teams. And you can see their scores kind of represented graphically, and the team name is on the left, and the score is on, team name is on the y-axis, and the bootstrap score is on the x-axis on the left. And then in the validation, we plotted the reproducibility of each team's algorithms. Next slide. So what the challenge motivated the development of algorithms to provide quick methods to assess joint damage, which is one of the first steps if we want to identify who may have erosive disease. And ultimately, these methods can potentially drive research studies on joint damage. And ultimately, we would love to have an algorithm like this on the computers of clinicians so that when they obtain x-ray films, they can objectively determine how the patient is doing compared to previous films and help use this to base optimal therapy. The major limitation of our study is that we had a very small training sample relative to others where there are hundreds of thousands of images. So the model may be overfit, but we do want to repeat this and have more training with the largest, most diverse populations possible. So this is a good first step. And the paper is in preparation. Next slide. So now I want to talk briefly about what can we do from the very different approach of machine learning and big data to really try to, this is a very interesting study in which the investigators tried to predict in 3 months who would have a flare of rheumatoid arthritis. Next slide. So this was from a group that was largely at UC San Francisco, and they used a deep learning model based on EHR data to try to predict the clinical outcomes in patients with rheumatoid arthritis. Next slide. So why is this important? So if a patient is going to have a flare, then we could try to do everything we could to ablate that. So we could change the medication. The patient might become more adherent to medication if we communicated this to them. And then ultimately, if we did have molecular and genomic data from patients at these time points, we might really be able to understand the pathophysiology of that particular patient and lead to a more personalized approach. And even, the first step would be to say, well, we now have a group of patients at risk for a flare, and we might do different strategies to test them. So next slide. So in this example, there were sets of data from 2 sources. One is a university hospital and one's a safety net hospital. And the gold standard, and you can see the numbers there for what they call the teaching set is when they develop their algorithms, and the testing is when they tested them against real data. You can see the patient numbers there. And the gold standard was 578 patients who they knew the clinical disease activity index at the follow-up visit. So they were asking the computers to predict which patients were going to have a flare 3 months subsequent to the visit. Next slide. The variables in the algorithm were those that were reliably in the EHR, and that included age, sex, ethnicity, the prior CDI scores, clinical disease activity index, the SED rate and CRP, the use of DMARDs, the use of oral or injectable glucocorticoids, the presence of rheumatoid factor and CCP. Next slide, please. So this is a receiver operating curve, and a perfect test would be one that starts at the 0 axis and on the y-axis goes rapidly up to 1 and then stays at 1 with false positive rates being near 0. And flipping a coin is represented by the dotted line. And the take home from this is when they looked at their university hospital cohort, they came up with an algorithm that was pretty accurate in predicting who would have a flare in 3 months, and that's represented by the blue line there, which is very reasonably close to the perfect. And so the area under the curve, a perfect test would be 1.0, theirs was 9.91. And they tested it against some other classifiers to make sure that there was no random effects there, and you can see that the deep learning model was very positive, was very helpful. Next slide. And then they then tested it in an independent cohort, which was from the safety net hospital. And you can see that the blue slide there is for the university hospital data alone. And then when they superimpose, I'm sorry, the blue line was for the safety net hospital alone. And then the black line at the top represents when they superimposed the data from UCSF, their university hospital, and their safety net hospital. You can see the area under the curve was not quite as favorable, but it did show some improvement compared to what you would use as a classifier, such as just looking at the CDI score at that visit alone. Next slide. So the conclusions are that the CDI scores alone are poor predictions of the next disease activity score, but they found a combination of prior CDI score, lab values, and medications that were the strongest predictor of the next CDI score. Some of these variables had time dependence, and what another conclusion is that a few hundred patients within a healthcare system would be sufficient for training. But when you then try to extrapolate your findings to another healthcare system, it was better, but not of immediate clinical utility. Next slide, please. So if the training sample is too small, you can overfit the model. They did not think that that was the case here, but as I mentioned with our radiograph challenge, you do need to train with the largest, most diverse population possible. A lot of things needed to be considered that were not necessarily in this model, but I think that the models are getting, as you can see on the last slide, good enough to warrant randomized clinical trials to see if they're really useful. Next slide. So the implications are many. There's a lot of situations where you don't really know what to do, where there's really no data to point you one direction or the other, equipoise. And this model would allow simulation of trajectories. And then there's a common clinical scenario where you have moderate disease activity and you might wait. But that may be where the model is most helpful. And it is consonant with movement toward personalized medicine with addition of molecular, genomic data, et cetera. Next slide. Just to point out that there are many other things being studied. This is just a couple examples. One is this is an ROC curve to try to identify difficult to treat rheumatoid arthritis patients using just what the labs that are in the clinical EHR, and this was a hackathon, which is a term that I've become more familiar with, where you get a lot of really bright computer scientists, data scientists, and clinicians interested in clinical research, and get in a room together or a virtual room together and work on the same problem and have a discussion. Next slide. And then another example is people are trying to integrate rheumatoid arthritis data, not only from the EHR, but from other mechanistic disease maps, so basically pathophysiological data, genetic data, et cetera. Next slide. So I want to just briefly in the last minute, and hopefully I'm not too far over, talk about resources for future approaches in just a couple examples. Next slide. So in the US, we have what's called the ACR, is what's called the Rheumatology Informatics System for Effectiveness, or RISE. ACR has done a great job. More than 2 million patients are represented in this. It involves about 33%, a third of all the practicing rheumatologists in the US. And so far, there have been more than 25 million patient encounters. And this was designed as a quality measure, not as a research measure, but a quality measure. So it allows the ACR to help rheumatology providers submit their data to Center for Medicaid and Medicare Services to show that their quality is the highest possible. Next slide. So eventually what we would like to do is to use the RISE data to ultimately lead to what you see on the right, a precision medicine initiative. Next slide. There is planning for this underway. Together we can advance rheumatology's emerging therapeutic strategies or targets. Next slide. And we hope that eventually targets using the ACR data and many collaborators, we can have really a Google map for health that will include many, many, many different data sets and big data. And this has been spearheaded by Januja Astani at UCSF. Next slide. And also Bill Robinson at Stanford. So ultimately, we'd like to get to Ehrlich's concept of the magic bullet, and the challenge is to get the right drug to each patient at the right time to improve their quality of life. Next slide, please. So thank you again very much for the opportunity to present today. If any of you is ever in New York, please look us up. We'd love to see you and have you come see our facility. Of course, after COVID is hopefully put to bed, or at least in the background and not such a prominent part of today's discussions. But I stop there, and thank you very much for your attention and for your kind invitation to present.
Thank you very much, Lou. That was a marvelous oversight of a futuristic attitude towards medicine. I think it's an eye-opener to many in the field and other fields. I'm checking questions. No, we have no questions. I thank you very much for accepting our invitation, and thank you for this wonderful presentation, and looking forward to see you in the ACR Convergence meeting.
Yes, thank you so much. Great to see you, and enjoy the rest of the conference, and thanks again for the invitation.
Thank you. Our next presentation is by Dr. Amr Idris. He's an associate professor in Kansas City, University of Missouri, and he graduated from Cairo University. And in the early years of his career, he proved to be a very disciplined, very successful, and an amiable person. He continued his career in the United States, where he's now presiding over the Kansas City University of Missouri Department of Rheumatology. Amr accepted our invitation, and we are pleased to have him to present updates on lupus nephritis, a topic that's ever challenging and ever undergoing changes.
I am Amr Idris. I am an associate professor of medicine and section chief of rheumatology in the University of Missouri, Kansas City. It is a great opportunity to be with my colleagues in Egypt to speak about lupus nephritis 2021 updates. Objectives, we will describe the diagnostic evaluation of patients with lupus nephritis. We'll describe the current treatment approach for lupus nephritis, and we'll highlight the new release data in 2021 for treatment of lupus nephritis and how to incorporate in clinical practice. Disclosure. Lupus nephritis, approximately 50% of lupus patients will develop clinical lupus nephritis, and about 20% of patients will progress to end-stage renal disease within 10 to 15 years of diagnosis. The way to decide on treatment is by kidney biopsy. The indication for kidney biopsy in lupus is mainly increase in serum creatinine without explanation, proteinuria, 1 gram protein in 24 hours, or proteinuria of half gram in the presence of more than 5 red blood cells per high power field or cellular cast. The classification of lupus nephritis is based on the International Society of Nephrology and Renal Pathology Society classification. We have class 1, which is minimal mesangial, class 2, mesangial proliferative lupus, Class 3, focal lupus nephritis. When there is less than 50% of the glomeruli affected, this could be active and chronic or chronic. Class 4 is diffuse lupus nephritis when there is more than 50% of the glomeruli and affected, and that could be also active, chronic, or active and chronic. Class 5, membranous lupus nephritis, and class 6 when there is advanced sclerosing lupus nephritis with more than 90% of the glomeruli sclerotic. In 2018, there was a revision on the pathology classification suggested. They defined class 2 by more criteria for mesangial hypercellularity to include more than 4 nuclei surrounded by matrix in the mesangial area. The term endocapillary proliferation was eliminated, and they used the definition of endocapillary hypercellularity. They eliminated the class 4 S and G, segmental and global, from the subdivision of class 4 lupus. And they recommended, instead of using the activity and chronicity indication, is to use the activity and chronicity indices that should be applied. There was a modification for the NIH activity index score from 0 to 24. The score mainly depends on the percentage of the glomeruli affected by the element of activity, either 1, 2, or 3. For each item, this is the endocapillary hypercellularity, the infiltration with neutrophil and the karyohexes, fibrinoid necrosis, wire lobe lesions and hyaline thrombi, presence of cellular and or fibrocellular crescent, presence of interstitial leukocytes. These items, the fibrinoid necrosis and the crescent, are weighted by 2 because they indicate high activity. The chronicity index score from 0 to 12 based on glomerulosclerosis, fibrous crescent, tubular atrophy, interstitial fibrosis. Other diseases that can affect the kidney in lupus other than lupus nephritis, we have the tubulointerstitial lesions. The severity of it correlates with prognosis. Vascular lesions could be because of microvascular thrombi or thrombotic microangiopathy or vasculitis, atheroembolic disease, and atherosclerosis. Other pathology includes the lupus podocytopathy, which can occur in 1% of biopsies in a lupus patient, mainly present by nephrotic syndrome. It mimics the minimal change disease. There is no significant changes in the glomeruli in the light microscopy. Sometimes there is some mesangial or focal segmental glomerulosclerosis. And mainly by electron microscopy, there is diffuse food process effacement on electron microscopy. And it usually responds to a short course of prednisone. Collapsing glomerulosclerosis is a pathology that suggests progression to end-stage kidney disease, and it's characterized by collapse of the glomerular capillary tuft within the Bowman cap space. Immunopathology in lupus nephritis is important and characteristic. We have the classic full house pattern because of the immunoglobulin G, M, A, and complement, all of them found in the deposits. That could be also helpful in some situation when the etiology of the glomerulonephritis is not clear for some patients who have negative serology or no extra renal manifestation. It can point to the etiology is lupus nephritis. Treatment of lupus nephritis will mainly focus on the class 3, 4, 5. These are the pathology that can progress to end-stage kidney disease. Why the treatment is difficult in lupus nephritis? Treatment is difficult because there is no agreement on complete response in patients with focal or diffuse lupus nephritis to treatment. The long-term response to treatment is unknown. The heterogeneous nature of the disease itself, like lupus, is not one disease. There is different manifestation. Also in the lupus nephritis itself, we have different pathology, and the different activity and chronicity factors can affect the treatment response. When we speak about lupus nephritis treatment, we mean mainly we focus on immunosuppressive medications, but there is other aspect of treatment that could be applied to every patient with lupus nephritis, which includes the use of hydroxychloroquine. It has been shown that the use of hydroxychloroquine decreases interstitial fibrosis, use of maximum tolerated dose of ACE or ARB to help with reduction of the proteinuria, blood pressure control to a goal of 130/80 or less, the use of statins. We pay attention to the bone health by vitamin D supplementation, and the use of FRAX to decide on need for anti-osteoporosis treatment, vaccination that should be given to patients on immunosuppressive medications. Evolution of lupus nephritis treatment. So the treatment of lupus nephritis passed through different stages. Like in the 1960s, the use of corticosteroid was started to be used in lupus nephritis. After that, in the 1980s and 1990s, the main treatment was the cyclophosphamide NIH protocol. The protocol developed through a series of studies that showed that the use of pulse cyclophosphamide in addition to corticosteroid was superior to corticosteroid alone. Then there's other studies that did show that extended course of pulse cyclophosphamide up to 30 months was associated with better rate of renal response comparing to the short course of pulse. So that was the main protocol used for several years, which is the NIH protocol by giving pulse IV cyclophosphamide based on the surface area, administered every month for 6 to 7 months, plus prednisone, followed by maintenance treatment with cyclophosphamide every 3 months for 2 years, titrated by the white blood cell count, plus low dose prednisone. In 2002, the Euro lupus nephritis trial introduced a new protocol for cyclophosphamide. So instead of using the NIH protocol, they did compare the NIH protocol for induction by the high dose to the fixed dose, 6 doses every 2 weeks, each is 500 milligram. And they did use azathioprine for maintenance after cyclophosphamide was stopped in both groups. And the study suggested that shorter duration and lower dose of cyclophosphamide was as if as the original NIH protocol, but less toxicity in patients. In 2004, the concept of sequential therapies for proliferative lupus nephritis was introduced by a study that compared the use of induction therapy initially with cyclophosphamide the NIH protocol, maximum of 7 monthly doses. Then subsequently, the patient were randomly assigned to one of the 3 maintenance therapies, either the original NIH maintenance, quarterly intravenous cyclophosphamide, or the oral azathioprine, or the oral mycophenolate. It did show that short-term therapy with intravenous cyclophosphamide followed by maintenance therapy with mycophenolate or azathioprine would be more effective but safer than long-term therapy with IV cyclophosphamide. And based on this study, the practice of using the mycophenolate for maintenance instead of the quarterly doses of cyclophosphamide started to be common in practice. In 2009, we have the ALMS trial that now comparing the use of mycophenolate for induction instead of cyclophosphamide. So patients were followed for 6 months and randomly assigned to mycophenolate versus IV cyclophosphamide, the NIH protocol. And at week 24, patients were analyzed for the primary endpoint. So again, the treatment protocol was MMF, 3 grams per day versus IV cyclophosphamide. The response was about the same. The primary endpoint was achieved here in 56.2% and here in 53%. But the study suggested that MMF is as effective as cyclophosphamide in induction, but could be more safe. In the group analysis, here is the MMF group, and here is the IV cyclophosphamide. The overall response was about the same between MMF and IV cyclophosphamide. In ethnic group analysis, the Asian was more responding to the IV cyclophosphamide, but not significant. In Caucasian, it's about the same. The main thing that came from here is that the other, which were mainly African American and Hispanic, did respond better to MMF. And based on that, it became the suggestion of using MMF for induction in African American and Hispanic rather than cyclophosphamide. Then we get in 2011, we have the study comparing mycophenolate and azathioprine for maintenance therapy for lupus nephritis. This was like 36 months, randomized double-blind study, and it did compare 2 protocols, oral mycophenolate 2 grams per day versus oral azathioprine 2 milligrams per kg of body weight per day. In patients who did meet the response criteria in the 6 months induction trial. The assessment was based on serum creatinine, renal flare, and the use of rescue therapy in lupus nephritis. It did show that mycophenolate was superior to azathioprine in maintaining a renal response to treatment and preventing relapse. In 2015, we started to get the concept of multi-target therapy for induction in lupus nephritis. This was a study in China, 24 weeks, randomized, multi-center study comparing 2 protocols, tacrolimus, 4 milligrams per day, plus mycophenolate, 1 gram per day, versus IV cyclophosphamide with the classic NIH protocol. Both groups were given high-dose steroid at the beginning, then taper course of oral prednisone. It did measure the primary endpoint with complete remission at 24 weeks. The result shows that the multi-target group did achieve better remission than IV cyclophosphamide. And this was like some extent like significant change in the treatment options became available. During the study, they did repeat renal biopsy for some patients, and it did show that the improvement in the activity index was also more superior in patients who get the multi-target therapy comparing to patients get cyclophosphamide. Tacrolimus is calcineurin inhibitor. It has immunosuppressive effect, but it also has antiproteinuric effect. Limitation of the study that it was only 24 weeks and only in Chinese population. In 2017, we tried multi-target therapy for maintenance treatment of lupus nephritis. Patients who were treated initially for induction were randomized to continue multi-target therapy for maintenance of remission, but by a smaller dose. Here, the tacrolimus became 2 to 3 milligram, and the mycophenolate 500 milligram to 750 milligram per day plus prednisone. And that was compared, and patients who received the IV cyclophosphamide were maintained on azathioprine, 2 milligram per day. The response was not different in terms of maintaining remission, but the study did show that the rate of maintaining remission here was higher than previous study that was using the mycophenolate. And the explanations that patients who underwent randomization here had higher percentage of patients that had complete remission comparing to the previous study like the ALMS study. In 2012, we had the LUNAR study, which did not meet the endpoints criteria, assessing the addition of rituximab on top of mycophenolate. But it did show improvement in the lupus activity parameters, but the kidney response was not different. This was a study that done in 2003 about high-dose cyclophosphamide. So immunoablation, like, this was mainly for patients with resistant and refractory life-threatening lupus. They did use a protocol of using cyclophosphamide 50 milligram per kg administered for 4 days. Then 6 days after the dose of cyclophosphamide, patient received rescue granulocyte colony stimulating factor. It did show effectiveness of this protocol in improving patients with refractory life-threatening lupus, but this approach has not been significantly evaluated. Then in 2021, we have new studies data. That was important. We have the 2-year randomized trial of use of belimumab in lupus nephritis. So the study did assess the efficacy of belimumab, BLESS lupus nephritis study. Belimumab is a monoclonal antibody that inhibits B-cell activating factor, and it is approved for several years in non-renal lupus. Analysis of the initial study did show that there was improvement in the proteinuria in lupus patients. So that did lead to the subsequent studies, the BLESS lupus nephritis. This was randomized, double-blind, 104-week trial. And at the screening, the patient should have a urine protein creatinine ratio of 1 or more, have kidney biopsy of class 3, 4, or 5, or combination of 3, 4, 5. Patient should have active lesions For active and chronic, it did exclude patient on dialysis, GFR reduction, below 30, previous failure of both cyclophosphamide and MMF, or if they did receive cyclophosphamide induction therapy within 3 months, or they did receive B-cell suppressing therapy within 1 year before randomization. Patients were, all of them, treated by high-dose corticosteroid at the investigator decision, followed by randomization into two protocol. The standard of care was divided based on either the Lupus Nephritis protocol or the ALMS protocol with MMF. Belimumab was given IV infusion, 10 milligram per kg in the treatment group, and the placebo in the placebo group on day 1, 15, 29, then every 28 days until week 100. Assessment at week 104. So the group gets the MMF, was treated by the target dose of 3 grams per day. Then after 6 months, the dose reduced to 1 gram. Group get the cyclophosphamide, get the Lupus protocol, followed by azathioprine. Primary endpoint was renal response, defined by urine protein creatinine ratio of 0.7 or less, stabilization of the GFR, and no use of rescue therapy for treatment failure. This was like something mentions that in the LEONARD trial, one of the factors that the rituximab could have not shown efficacy is that they did not limit the use of rescue therapy or the dose of prednisone in both arms of the study. Secondary endpoint was urine protein creatinine ratio less than 0.5, GFR no worse than 10% below the pre-flare value, or 90 ml per minute or more, no rescue therapy. Also, the primary renal response at week 52, time to renal related event or death, lack of urinary sediment. The patient were considered treatment failure if they are requiring to be on higher dose of prednisone, which was patients were tapered to glucocorticoid to 10 milligram or less at week 24. And they don't have to be above this treatment. Or did use other immunosuppressive medications. There was 448 patients underwent randomization, 224 in the belimumab group and 224 in the placebo group. Standard of care, MMF, cyclophosphamide. At week 104, there was a significant difference in the primary efficacy renal response between the belimumab in compared to the placebo group. So more patients in the belimumab group achieved the renal response. And also the response was different from week 24, that the belimumab group is achieving the renal response. And the response was sustained. There was more patients in the mycophenolate group who showed the benefit. Like in the MMF group, the percentage of patients that did benefit from belimumab was higher. But in the cyclophosphamide azathioprine group, there was no significant difference between the belimumab and the placebo group. Patient with belimumab group had better laboratory parameter. The safety was no difference. In the cyclophosphamide azathioprine group, it was noticed that patient had higher level of urinary protein, lower GFR, longer disease, more history of treatment comparing to the MMF group. A limitation, the study did not compare other protocols. There was low number of black patients. In December of 2020, the FDA approved belimumab for treatment of lupus nephritis IV and sub-Q. Another study came also in the same time, 2021, is the efficacy and safety of Volcasporin for lupus nephritis. So Volcasporin is a new drug. It is a calcineurin inhibitor created mainly for lupus nephritis, not for other indication. It has better pharmacokinetics, so it does not need drug monitoring. And it has better profile on the lipid and glucose concentration. The Aurora 1 study compared, it was a randomized phase 3 study, compared the addition of Volcasporin in patients with class 3, 4, and 5, alone or in combination. Patients were randomized to either Volcasporin, a dose of 23.7 milligram twice daily, or placebo on a background of mycophenolate. Most of the patients were getting the 1 gram twice daily, and some patients was getting the 3 gram rapidly taper low dose oral prednisone. Lupus nephritis has to be active, and all patients had kidney biopsy. All patients had initiated initially on a methylprednisolone, a high dose, then a rapid taper of oral prednisone on day 3 to dose of 20 to 25 milligram per day, decreased to 2.5 milligram per day at week 16. So there was limitation on the use of prednisone in the study. The primary endpoint was complete renal response by the urine protein creatinine ratio of 0.5 milligram or less, and stabilization of the GFR. And no administration of rescue medicine. No more than 10 milligram of prednisone per day for 3 or more consecutive days, or for 7 days or more during week 44 to 52. Patients were assessed, and it did show that the Volcasporin group had better response in achieving the complete renal response than in the placebo group. Adverse event was similar between two groups. Here is a summary of the Volcasporin group and placebo group complete renal response at week 52, and also the secondary endpoints. It was met more on the Volcasporin group. Calcineurin inhibitor have two mechanisms, the immunosuppressive mechanism and the protective effect on podocytes that decrease the proteinuria. Based on this study, Volcasporin is able to achieve better improvement in lupus nephritis on a background of mycophenolate. There was 20% improvement when we did use Volcasporin comparing to MMF alone. Limitation of the study, lack of activity and chronicity in disease. Most patients had biopsies within 6 months of screening, but there was no chronicity or activity assessed before the study. And it is only 52 weeks. Currently, there is another study extended for 2 years to assess the response. Nobility Study, this was a 2-year study for obinutuzumab. This study showed that obinutuzumab is a new anti-CD20 monoclonal antibody, has better efficacy than rituximab, modified to be more cell-mediated cytotoxicity and more effective in B-cell depletion. Patient with class 3, 4 were randomized to receiving mycophenolate, steroid, to blinded to obinutuzumab or placebo. It was given as like zolbetuximab, 1,000 milligram at week 02, then 1,000 milligram at week 24, 26. And the primary endpoint was assessed at week complete renal response at week 52, and patients were followed for 104 weeks. The response was higher in the patient who had received the obinutuzumab maintained the response for 18 months after the last infusion, and the complete renal response with different criteria was met more in the obinutuzumab group. So the Nobility Study did show that use of B-cell depleting therapy that could be more strong or more effective than rituximab could be an option for treatment. There was another study that did compare a trial of rituximab plus cyclophosphamide followed by belimumab for treatment of lupus nephritis. That was mainly used for patients who have refractory and recurrent lupus nephritis. So patients were either receiving RCB, rituximab, cyclophosphamide, belimumab, or rituximab and cyclophosphamide only. The difference was not significant by adding belimumab on top of rituximab and cyclophosphamide in improving the renal response. Question important: should we repeat the kidney biopsy during treatment? That question was raised because there is assumption that repeating kidney biopsy after 12 months of immunosuppressive treatment may improve the outcome. Several studies have shown that signs of histologic activity of lupus nephritis may continue even in patients with complete renal response. And retrospective analysis that shows that some of the patients who had a recurrence after complete renal response had activity index score above 3. That is why the rebiopsy lupus nephritis study was started in 2021. Patient will be treated for 1 year according to the standard of care. Then they will be randomized to 2 groups. Biopsy will be treated. 2 groups. Group will be treated based on biopsy, and group will be treated based on the standard of care. So in the rebiopsy group, when they do the biopsy at 12 months for patients who have complete renal response, if they have activity index above 3/24, they will be treated again by intensive treatment. The goal of the study is to show that for patients who had complete renal response in 2 years will be higher in the rebiopsy group after 2 years. And percentage of patients with decreased kidney function at 5 years will be less in the rebiopsy group. If this study did show the correct hypothesis, rebiopsy after 12 months would be part of the renal treatment protocol for lupus nephritis. So this is a rebiopsy trial. So what is the best treatment now for lupus nephritis? The treatment is a combined decision between rheumatologist and his patient. Many factors could affect the choice: age, race, cost, desire for pregnancy, extrarenal lupus. And at the end, you will need to extrapolate. We have a specific group: severe lupus, resistant lupus, recurrent lupus nephritis, women desire future pregnancy. In 2019, there was some guidelines came from the EULAR about how to improve outcome. And it is mainly based on 2 targets. The target is the urine protein. So at 3 months, you need to see 25% reduction in urine protein, and at 6 months, you need to see 50% reduction, and at 12 months, you need to lower the urine protein to less than 500 to 700 milligram per day. The use of mycophenolate and Euro-Lupus protocol is part of the standard of care. There is data that suggests that lowering the glucocorticoid dose, cumulative dose, is beneficial. So treat to target approach mainly based on urine protein response. Lesson learned from the new studies: combination therapy could be better than sequential therapy. Initial therapy rather than induction therapy, because the concept of induction could not be applicable for disease like lupus nephritis, more like chronic form of treatment, and subsequent therapy rather than maintenance therapy. Initial treatment, we have the IV cyclophosphamide, now the NIH protocol, we have the Euro-Lupus protocol, we have the oral cyclophosphamide, 1 to 1.5 milligram per day, we have the oral MMF, and we have the multi-target treatment. Subsequent treatment, we have the IV cyclophosphamide, the oral azathioprine, the oral MMF, and the multi-target therapy by tacrolimus and mycophenolate. We have also the addition of belimumab on top of mycophenolate or IV cyclophosphamide, but again, it did show more benefit when it was added on mycophenolate. We have the Volcasporin on top of mycophenolate, and we have the option of pertuzumab on top of mycophenolate. Patients who have primary resistance, mean failure to respond, will need to change to alternative treatment if the patient is not responding. Relapse during subsequent treatment, patient who had mild relapse will be treated by increased dose or change or to other subsequent treatment. Major relapse, restart with the initial treatment. Refractory disease, patient who does not respond, you will have the option to extrapolate. You can use B-cell depleting therapy by adding rituximab or obinutuzumab on top of mycophenolate, and that could be also in addition to belimumab. We have the immunoablation with cyclophosphamide, IVIG, plasmapheresis, and co-stimulatory molecular inhibitor, leflunomide. All of that has no strong data on it. For women who desire future pregnancy, initial treatment usually will be by MMF-based treatment with birth control. Achieve urine protein creatinine ratio of less than 500 milligram for 6 months without use of ACE or ARB before you allow the patient to try to get pregnant. Then you withdraw of mycophenolate for 3 to 6 months before attempt conception. The subsequent treatments that can be allowed during pregnancy will be azathioprine, calcineurin inhibitors, prednisone, and hydroxychloroquine. Insights from kidney pathology, there is suggestions that patients with class 4 who have fibrinoid necrosis and cellular crescent, some of them will respond better to the IV cyclophosphamide NIH protocol as initial therapy, or the oral cyclophosphamide, and that is, these patients are like patients who have RPGN, do better with cyclophosphamide. Class 5 with heavy proteinuria, calcineurin inhibitor could be an option. Class 6 with rising creatinine, you need to consider tapering of immune suppression. So the addition of calcineurin inhibitor can improve the treatment either by using the tacrolimus or the Volcasporin. And this is the last slide. So we are now in speed race trying to achieve better response for lupus patients. Thank you.
Thank you, Dr. Idris, for your overreaching presentation. It was historical and updated at the time. And thank you for all the effort you did in preparing this wonderful presentation. I will check if there are questions. I have noticed that there were some. There is a question from Dr. Excuse me. I had a question here from Dr. Mariam. It doesn't show. I failed to connect. There's technical difficulty here. I have to recall. Yes, here we go. From an anonymous attendee, when do you consider renal replacement therapy rather than stepping up treatment?
Again, what is the question?
When do you consider renal replacement therapy rather than stepping up treatment?
Sorry, Dr. What is the question, sorry?
When do you consider renal replacement therapy rather than stepping up treatment?
Like when we start with combination therapy?
When do you consider when do you consider renal replacement therapy rather than stepping up medication or medical treatment?
Renal replacement therapy means initiating the dialysis. That is mainly based on if the biopsy did show that there is significant scarring in the kidney and significant fibrosis, and the serum creatinine is not responding to treatment, that indicates that the patient did approach end-stage disease, and in that situation, we'll need to initiate the renal replacement, but that require kidney biopsy. Like it has to be defined by kidney biopsy that this is an end-stage kidney.
Another question from Dr. Mariam. I can't see it here, but I remember seeing it before. What would you suggest to manage podocytopathies? What is your best option for treatment?
Usually it is a benign responding to prednisone, like few months of oral prednisone taper, it will respond to treatment.
So thank you very much, Dr. Idris. Any other questions? Okay, we proceed to the next presentation. Are we linked to Professor Dr. Stoll? The next presentation, and the last one, but not the least definitely, is presented by Dr. Matt Stoll, the Associate Professor of Pediatric Rheumatology at the UAB, or the University of Alabama at Birmingham. He has been a pioneer and a prolific researcher in the field of the microbiome in particular, and we'll be pleased we are honored by his acceptance of our invitation, and we are ready to hear his presentation. Thank you, Dr. Matt Stoll, for accepting our invitation.
So thank you for the very kind words and for the invitation to speak on the diagnosis and management of juvenile arthritis. Unfortunately, though, there will not be any discussion of the microbiome this afternoon. So briefly, I'm going to go over classification of JIA. We developed criteria in 1977. At the time, it was called juvenile rheumatoid arthritis in the US and chronic arthritis in Europe. And there were three categories: poly, and systemic. And the psoriatic and spondyloarthritis was not part of this classification set yet. The ILR committee came along initially in 1997, I believe, to generate some new criteria. The most recent update was 2004. And this does include psoriatic and spondyloarthritis. And in the process, there was a name change from JRA to JIA, juvenile idiopathic arthritis. I'll briefly run through the different categories. Oligoarthritis, this is defined by less than 5 joints during the first 6 months of disease. Persistent means they never develop more than 4 joints. Extended means they develop 5 or more joints after 6 months of disease. This mostly involves the knees and the ankles. Females are affected more often than males. And at least in Northern European ancestry individuals, the typical age of onset is 2 years. RF negative or seronegative polyarticular JIA, this is defined by 5 or more joints within the first 6 months. This also impacts females more than males, and there's an onset throughout childhood and very variable joint involvement. It can be asymmetric, not always, and does not necessarily spare the DIPs. Seropositive, this is a symmetric polyarticular arthritis, also females more often than males, mostly teenagers. These children are RF positive, anti-CCP positive. They have the HLA-DR4 shared epitope. So this is rheumatoid arthritis by a different name. It's the same disease, same genetics, same manifestations. However, it only constitutes 2 to 5% of all of JIA. Emphasitis-related arthritis, some of you may know this is my favorite category. This is juvenile spondyloarthritis. Depending on the series, somewhere between 1/3 to 3/4 will carry the HLA-B27 marker. This has an even joint or sex distribution, males equals females. As with spondyloarthritis in adults, this primarily affects the large joints and the lower extremities. Peripheral arthritis is more common at onset as compared to adults who have AS, in whom they often present with spinal involvement without any peripheral. As with adult spondyloarthritis, they have appendicitis, dactylitis, gut inflammation, and maybe 1/2 to 2/3 of the cases are very similar. And we diagnose sacroiliitis with MRI. As opposed to adults, advanced radiographic changes are less reliably present in children. So they have what in the adult literature is referred to as non-radiographic axial spondyloarthritis. And so we rely upon bone marrow edema to make the diagnosis of active sacroiliitis. One difference, though, in children versus adults is that the presence of red marrow or hypercellular bone marrow complicates interpretation, and that's shown on the next slide. So this is a sacroiliac joint MRI. You'll recognize this as being in a younger child, as evidenced by the fact that sacroiliae have not fused here, as opposed to what you would see in an adult sacrum. What stands out is this bright signal here at the margins, which if you saw this in an adult patient, you might think this is periarticular bone marrow edema suggestive of sacroiliitis. This is in fact, in this child, normal age-related changes of red marrow. And one of the clues is that the red marrow really hugs the surfaces here, both at the margins here, then inferiorly, superiorly here, and when you, as if someone had drawn a magic marker over this area. And when you see that, that's a clue, especially in a young child, that this is normal red marrow and not active sacroiliitis. Psoriatic arthritis, as opposed to the adult counterpart, arthritis precedes psoriasis in at least half the cases. So we have clinical features that can predict the development of psoriasis. And so long before the adults had the Casper criteria, we recognize features such as nail pits, a family history, and dactylitis as being features that predict future development of psoriasis and psoriatic arthritis in a child with arthritis. This is about biphasic age of onset with a peak at age 2 to 3 and a second peak at age 10 to 12. And there are some differences between early and late onset psoriatic arthritis, in that specifically the adult onset children, or the late onset children, I should say, have features of spondyloarthritis more so than the early onset, including enthesitis, psoriasis, axial disease, and positive B27. Systemic onset JIA. These children come in with fevers, rashes, lymphadenopathy, hepatosplenomegaly, marked systemic inflammation, and arthritis. They can also develop, not shown in this slide, macrophage activation syndrome. So they can be quite ill at presentation. This is what the rash looks like. And classically, it's described as a salmon colored rash that can come and go when they have the fevers. This is what the fever curve can look like. And you can see there are high spiking fevers, maybe once or twice per day, and they can even come down below normal in between fever spikes. Finally, undifferentiated JIA. These, by definition, meet criteria for no specific form of JIA or for 2 or more. It results from exclusion criteria designed to ensure mutually exclusive groups. An example is if you have a child with RF polyarticular JIA who also has psoriasis, the psoriasis is actually an exclusion criteria for seropositive. And so it ends up being a wastebasket of multiple different categories and phenotypes. Diagnosis. The general definition requires arthritis with onset under age 16 without any other cause, hence the idiopathic, and lasts at least 6 weeks. Antibodies classified, but they are not required for diagnosis. This slide summarizes the different lab abnormalities we can see in different categories of JIA. A positive ANA is pretty frequent in oligo and polyarticular JIA, especially RF negative, as well as in psoriatic, especially younger onset children, but is not present in the ERA category or systemic any more than whatever the population frequency is. By definition, the RF is seen in children with RF positive polyarticular who often have a positive anti-CCP antibody, but is not seen in any of these other categories. HLA-B27 is seen, of course, in children with ERA, but not so much the other categories, except maybe the older onset psoriatic. And the inflammatory markers can be normal or elevated in most categories, aside from the systemic, where it tends to be very highly abnormal. So the message here is that normal labs do not exclude JIA. Briefly, I'll just speak to uveitis, since that comes up in treatment as well. Location in children with arthritis is typically anterior or intermediate chambers. Posterior uveitis is rare. Clinical features, this is typically silent unless it's associated with spondyloarthritis. So children, as with adults with B27 associated arthritis, it can be red, painful, unilateral. However, absent of that phenotype, uveitis is silent and it's not evident until they've had this for a long time, they've had chronic changes. Risk factors are early age of onset and a positive ANA, and this can cause blindness if not treated. Differential diagnosis depends on the presentation. So in general, other conditions that can mimic JIA include a variety of infections, cancers, trauma/overuse, and other rheumatic diseases. And which infections and which type of cancers depends on the overall presentation, whether you're looking at a child with 1 or 2 involved joints, a child with polyarticular arthritis, sacroiliitis, or systemic. So I'm going to now speak to some of these specific mimics of JIA. Malignancy. It can be very painful for everyone involved if a child with arthritis, with a child with cancer is misdiagnosed as having JIA. Cancer can be the underlying diagnosis in a systemically ill child, and the 3 that often present with systemic inflammation, fevers, lymphadenopathy, and so forth, are lymphoma, leukemia, and in young children, neuroblastoma. Cancer can also present as limited bone pain in an otherwise well child. So where do you suspect malignancy? There was an excellent study that was published, that was still in press from this year. This is an Italian study where they looked at 2,000 children diagnosed with either malignancy or JIA. Of the 1,200 that ended up being diagnosed with malignancy, A quarter of them had musculoskeletal symptoms, the sort that we might associate with JA, including joint pain, decreased range of motion, arthritis, and limp. So they performed a multivariable analysis to try to tease out which features predict cancer versus arthritis. And the results are shown here. Anything with an odds ratio greater than 1 was predictive of cancer. Anything with an odds ratio less than 1 at the bottom of the slide is predictive of arthritis. So bone pain, weight loss, a low platelet count, monoarticular involvement, hip involvement, and male sex were all predictive of cancer, whereas morning stiffness, joint swelling versus pain, small involvement of small hand joints, and constant pain were predictive of arthritis. Additional messages from the study are that systemic symptoms were not always present. For the hematologic cancers, lymphoma, leukemia, they are present most of the time, 83%. For solid cancers, it's 50-50. MSK symptoms can be the only finding. This is rare in hematologic cancers, but it's still present in 5% of those cases, and a little more frequent in the solid cancers. And most cancers were oligoarticular, with a median number of involved joints being 2, with an IQR of 1 through 3. So again, the child has polyarticular arthritis, probably not cancer. All right, so some other diseases that can mimic JAA. Kawasaki is one. This is a multi-system inflammatory disease with the cardinal symptoms of fever for at least 5 days, conjunctival injection, oropharyngeal changes such as chapped lips, fissure tongue, cervical adenopathy, rash, and extremity swelling or desquamation. Systemic JAA and Kawasaki have some overlapping features. Both present with fever, rash, adenopathy, HSM, and abnormal labs. Arthritis is not always present at the onset of systemic JAA and can be present in KD as well. So the presence versus absence of arthritis does not necessarily rule one in or out. Furthermore, there's been a report in 2005 of children with coronary artery aneurysms who are subsequently diagnosed with systemic JAA. So if you have a young child who comes in with features of Kawasaki, including coronary changes, who persistently has fever despite treatment with IVIG and other therapeutics, at some point it's possible that their diagnosis will emerge to be systemic arthritis. A more recently recognized syndrome is MIS-C. This is a multi-system inflammatory disease, by definition secondary to SARS-CoV-2 infection. It has a number of overlapping features with Kawasaki, including fever, conjunctival injection. It has more GI symptoms compared to Kawasaki, abdominal pain, diarrhea. They can be prominent. We've had some patients who had their appendix removed and then were diagnosed with MIS-C. They get rash and they have myocardial dysfunction with or without coronary artery aneurysms. So when do we suspect MIS-C? Well, certainly in the context of a pandemic, and for as long as this pandemic is ongoing, then we're going to be seeing, unfortunately, MIS-C. So they have a known recent SARS-CoV-2 infection within the last month, especially as a risk factor. They have Kawasaki symptoms, especially in an older child, and there's significant cardiac involvement. Even those should raise the high possibility of this diagnosis. Next, I'll move on to infectious mimics of JIA. And there are 3 infections in particular that can easily cause and be mistaken for JIA. Or I shouldn't say cause JIA, but be mistaken for it. Lyme, Dinococco arthritis, and chikungunya. Lyme arthritis is not seen in Egypt very often, if at all. It has a very interesting history that we summarized in a textbook that Dr. Daub and I co-edited along with Dr. Atkinson here at UAB. There was a peculiar cluster of, quote, JRA cases in a single town in the mid-1970s. This struck the rheumatology fellow, as being unusual, since this is a 1 in 2,000 diagnosis. There should not be a cluster of cases. Many of them were preceded by a rash that's not typically seen in JIA or not seen at all in JIA. And so Dr. Steer postulated an association between the Uveitis tick and this rash and the arthritis, and this was subsequently confirmed. So where do we see this? We see it in the US, especially in the Northeast and Mid-Atlantic areas. It's seen in various areas in Europe, but it's rare in other continents. Dinococco arthritis. This is seen typically in adolescents and young adults, both males and females. They can have fever and chills. This can present as a polyarticular arthritis with a tenosynovitis as well. And then they get this dermatitis shown over here, a blister with a necrotic roof and a halo erythema that is a very strong clue that this is a gonococcal arthritis. And if you don't think about the diagnosis, you won't make it. It can be missed. Chikungunya is an emergent form of arthritis. This is an arthropod-borne flavivirus, the Zika virus, transmitted by mosquitoes of the Aedes genus. It's been identified all over the world. At least a mosquito has, in many of these countries as well, shown over here. The infection has been reported. They'll develop an acute onset of fever and rash. With the rapid onset of rheumatic manifestations, they can have a polyarticular arthritis, can be symmetrical. They can have enthesitis as well. In about half of these cases, the arthritis can become chronic, and there may be a role for immunomodulatory treatment in these patients. Infectious sacroiliitis. These patients present with high fevers and a sudden onset of pain. So that's typical, or I'm sorry, this is the opposite of what's typically seen in spondyloarthritis, where an insidious onset is one of the features that defines inflammatory back pain. On imaging, you're looking for inflammation that crosses fascial planes. So you can see here, bone marrow edema is pretty typical, but there's also involvement in the nearby fascia, and that would be more suggestive of an infectious cause. Anything that can cause a septic arthritis can cause sacroiliitis, but also brucellosis and tuberculosis can also cause this. Now we're going to move on to treatment. And I'm going to hit some of the highlights, since many of the same medicines that we use to treat arthritis in children are also used to treat arthritis in adults. 2 years ago, I was part of a group that was supported by the American College of Rheumatology to provide treatment recommendations, updated treatment recommendations in children with arthritis, as well as for uveitis. I'll hit some of the highlights of this and then move on to some controversies in the management of JIA. The targeted patient groups for polyarthritis, 5 or more joints ever involved, regardless of the category, ILR category. A separate targeted group is sacroiliitis. A third targeted group was enthesitis. And in a separate publication that involved ophthalmologists, we spoke to recommendations for uveitis associated with JIA. So recommendations are stratified by the presence versus absence of risk factors. Risk factors include positive anti-CCP antibodies and the presence of joint damage. This is stratified as well by disease activity based on a low CJ-DAS versus moderate to high. The CJ-DAS is a score that ranges from 0 to 30. You get up to 10 points for the physician global assessment of disease activity, 0 being great, 10 being as high as it can be. There are 10 points for the patient or parent assessment of disease activity, and another 10 points for swollen joints. There were swollen or active joints present. If there are more than 10 active joints in the patient, then it gets capped at 10. So the highest score would be 30. So low is less than or equal to 2.5. Moderate or high is more than 2.5. General recommendations. NSAIDs are limited to adjunctive therapy. We don't like long-term use of non-steroidal anti-inflammatory drugs. Likewise, oral corticosteroids are acceptable as bridge therapy for patients with moderate disease activity, but not for long-term use. Methotrexate is the preferred non-biologic DMARD. Combination therapy of methotrexate with biologic DMARDs is preferred over monotherapy alone. So a patient comes to you with JIA, with polyarticular JIA. We recommend methotrexate over triple therapy, and this is different than what's recommended in adults, where triple therapy of methotrexate, sulfasalazine, and hydroxychloroquine can be considered an acceptable first-line option. In children, in the absence of risk factors, methotrexate, and I identified those earlier, the anti-CCP or joint damage, methotrexate is recommended over a biologic. The next bullet point took us really a whole session, a whole morning to hash out, because there were some very divergent opinions here. With risk factors, Methotrexate is still recommended over a biologic, recognizing that there are situations where initial therapy that includes a biologic may be preferred. And I'll talk some more about that debate later on when I show some of the data for or against upfront use of biologic along with methotrexate. Escalation of care. We recommend adding or changing a DMARD or a biologic even if there's low disease activity. So if the patient has a CGAS of 2, so it's active but overall doing well, we recommend making a change in some level to try to get this under control. Adding a biologic is preferred over triple therapy. The biologics we spoke to are TNF inhibitors, abatacept, or tocilizumab. The recommendations preceded the tofacitinib study that resulted in the approval of tofacitinib and JIA, so we were silent on this medication. If a patient is already on a TNF inhibitor and has active disease, we recommend switching to a different mechanism of action versus a second TNF inhibitor. All right, next we spoke to sacroiliitis. Treatment with an NSAID is recommended over no treatment. If there's active disease despite NSAIDs, we provided a strong recommendation for use of a TNF inhibitor versus NSAID monotherapy. If TNF inhibitors are ineffective or contraindicated, we provided a weak recommendation for sulfasalazine. The recommendations were largely silent to IL-17 inhibition. As of now, there are no published data supporting the use of IL-17 antagonists in children with ERA. There was a study that was completed and was presented at the EULAR conference this summer that showed that IL-17 inhibition is effective in children with ERA. And I'm hopeful that we will have this published, and this will be published and approved in the near future. And if this occurs, then I anticipate the next time we publish guidelines on sacroiliitis in children, that these will be included. Emphasitis. Treatment with an NSAID is recommended over no treatment. If there's active disease despite NSAIDs, then we provide a conditional recommendation for use of a TNF inhibitor. Methotrexate or sulfasalazine can be considered for mild cases, and we provide a conditional recommendation for physical therapy because of the well-recognized association with biomechanical forces and propagation of the disease of spondyloarthritis. Screening for silent uveitis. So the next publication was on uveitis in JIA. Children who have oligo or polyarticular arthritis, RF negative, psoriatic and undifferentiated in general are considered to be higher risk than those with systemic arthritis, polyarthritis, or enthesitis-related arthritis. So the high-risk categories, those are the high-risk categories. Additional risk factors are positive ANA, age of onset less than age 7, and a short disease duration. Anyone with any of those risk factors, or all of those risk factors, we recommend screening every 3 months. If one or more of those risk factors is missing, then screening every 6 to 12 months is acceptable. Initial treatment. Topical corticosteroids are okay for short-term control. However, if the uveitis is persistent, then we recommend starting, changing, or adding systemic therapy. First line is subcutaneous methotrexate. If there is severe or vision-threatening uveitis, then we would recommend at least considering adding a TNF inhibitor immediately along with methotrexate to prevent blindness. Escalation of care. If a patient is on methotrexate, we'd have them add a TNF inhibitor monoclonal antibody, so adalimumab or infliximab, as opposed to etanercept, which both the pediatric and adult guidelines reflect is not effective for uveitis. If the patient still has active disease, then escalate the dose, for example, weekly adalimumab. If they still have active uveitis, switch to a second TNF monoclonal antibody. And if they still have active uveitis, then consider non-TNF biologics. There are very little data on what to do in this situation. We spoke to abatacept or tocilizumab, or non-methotrexate DMARDs, cyclosporin, flufonamide, or mycophenolate. Finally, recommendations for systemic JA with systemic symptoms. These were not addressed in our most recent update, and so I will refer to the 2013 recommendations. It is well recognized that IL-1 and IL-6 are involved in pathogenesis, so we recommend, actually I wasn't part of these recommendations, but The recommendations are to treat with IL-1 or IL-6 inhibition, as opposed to methotrexate and TNF inhibitors, again, for patients with active systemic symptoms such as fever, rash, and elevated inflammatory markers. So now I'm going to speak to controversies in the treatment of JIA. The first one is early aggressive therapy. There are also a number of questions regarding safety of these therapeutics. Early aggressive therapy. The idea here is that there is a window of opportunity. And the theory behind this, or the argument behind this, I should say, is that if you do not bring the child into remission quickly after symptom onset, the biology of the disease changes and it becomes more difficult to treat down the road. The implication of this is that step-down approach is favored over step-up. So proponents of early aggressive therapy recommend throwing everything you can at them at the beginning, get the disease under control, and then once it's under control, you can back off of therapy. So what are the studies that support this, or that were intended to support this? There are two of them. The first is the TREAT study, which stands for Trial of Early Aggressive Therapy. This was a randomized controlled trial. Children with polyarticular course JAA with less than 12-month duration who were naive to biologic therapy were enrolled. There were two treatment arms. Arm 1, children received methotrexate, 0.5 milligrams per kilograms, along with etanercept at standard doses and a prednisolone taper. Arm 2, the children received methotrexate plus placebo etanercept and placebo prednisolone. So this was blinded. The primary outcome was clinically inactive disease at 6 months. Definitions. Clinically inactive disease requires no active joints, no fever or other systemic symptoms attributable to JIA, no uveitis, a normal ESR, and an MD global of 0. Clinical remission is 6 months of CID. This is an overview of the study. Children were randomized to Arm 1 or Arm 2. Again, Arm 1 received methotrexate, etanercept, and corticosteroids. Arm 2 received methotrexate alone and placebo. At month 4, it was assessed whether they had an ACR pediatric 70 score. This is similar to the ACR 20 that's used for RA therapeutics. This would require a 70% improvement in 3 of the 6 domains, with worsening in no more than 1 of the domain. These domains would include the patient global, number of swollen joints, number of limited joints, so forth. If the ACR 70 was achieved at month 4, they continued on blinded treatment, Arm 1 or Arm 2. If it had not been achieved, then they received open label etanercept and prednisolone in addition to the methotrexate. Then at month 6, the study team determined whether clinical inactive disease was obtained, and then they continued for several years as follow-up. This is the primary outcome. The presence versus absence of clinically inactive disease at 6 months. You can see that for their first 4 months, we only had Arm 1 and Arm 2. Then beginning of 4 months, some patients received open label, etanercept, and prednisolone. At 6 months, the presence versus absence of CID, clinically active disease, was assessed, and it was higher in the patients initially assigned to Arm 1, although this is not significantly so. And at month 12, there's still a trend towards better outcomes in patients who were on Arm 1 initially, although this is close. Secondary outcome, the pediatric ACR 70 response. Again, this is very close at 6 months and 12 months, maybe a little bit higher in Arm 1, but not substantially so. So in 2014, so 2 years after this was published, Dr. Wallace published a long-term follow-up of these patients who at this point had 28 months of, on average, 28 months of follow-up. Now, there's a really jaw-dropping important admission that was made here that I'll read to you. Treatment arm did not predict CRM, that's clinical remission on medicines, or length of clinically inactive disease. In other words, as much as many of the proponents of early aggressive therapy use the study to justify early aggressive therapy, when you look at them in 2 years out, it didn't matter. They were equally likely to be in remission and had an equally long length of CID, regardless of which arm you assigned them to at the beginning of the study. That was a treat study. Second is the STOP JIA, start time optimization of biologics and polyarticular JIA. This also enrolled children with polyarticular JIA. This was a consensus treatment plan, or CTP approach. These children were not randomized. Instead, this was done throughout the country, sites throughout the country, and rheumatologists who enrolled the children could treat them however they thought was appropriate based upon their personal standard of care, based upon the disease activity, and the patient family preferences. And the idea was you take all these different approaches of children with JIA and then compare them a year out. There were 3 arms. Step up. These are rheumatologists who started their patients on methotrexate and then added the TNF inhibitor if needed. Early combination. These are children who receive methotrexate and a TNF inhibitor from the beginning and biologic first. The primary outcome was CID, clinically inactive disease, off glucocorticoids at 12 months. So these are the baseline characteristics. Because this was not a randomized trial, because this was a CTP approach, the baseline characteristics are not going to be equal between the 3 arms, and they were not. They were similar with respect to age, percent male, and the disease duration in months. However, the children who received combination therapy were more likely to have seropositive disease. They had a higher MD global, a higher parent global, a higher JDAS, all this is close. This is Juvenile Arthritis Disease Activity Score, and a higher joint count compared to those who are assigned to step-up approaches. Primary outcome. In the unadjusted analysis, the percent with clinically inactive disease was 32% in the step-up approach and only 37% in the early combination, and if anything lower in the biologic first, although these differences were not at all significant. Now, of course, I pointed out in the last slide that children who received the early combination had a little bit more aggressive disease to begin with. So they adjusted for this in a variety of propensity analyses, multiple imputation, and even with all of that, the percent with CID was still higher in the early combination versus the step up, but not significantly so. And especially when you look at the biologic first, where it may have even been a little bit lower compared to the step up, although again, none of these p-values were less than 0.05, none of them were statistically significant. Now, when they look at the secondary outcomes at ACR 70, they did see that the early combination led to, and this is after they did all the fancy statistics, that the early combination did result in a higher ACR 70 score and a higher likelihood of CJDS and active disease. You ask the patients how they're doing. These are a couple of patient-reported outcomes. The pain interference T-score, the higher this is, the worse they are. The mobility T-score, the lower this is, the worse they are. In both cases, biologic first, and I did not see p-values in the publication. In both cases, biologic first was perhaps worse than their 2 groups, but the 2 other groups, the early combination and step up, were virtually identical across the board over 12 months. So the key might be how quickly you start any treatment. This was also an offshoot of the TREAT study. Here, Wallace looked at the probability of having any visit in clinically inactive disease and the duration of signs and symptoms of JIA prior to initial therapy. And this is regardless of treatment assignment. And what she found is that the longer you had symptoms prior to any treatment, the less likely you were to be in clinically inactive disease at any point after initiation of treatment. However, even little old sulfasalazine can influence the likelihood of being in remission down the road. It doesn't require modern therapeutics to have this effect. In 2002, a randomized controlled trial of sulfasalazine in children with JIA was published. This was conducted from 1992 through 1994, not published until 2002. A long-term follow-up was assessed between the years 2001 and 2003, that was published in 2007. So the post-trial medication use was similar between the 2 groups. Here we're looking at sulfasalazine, methotrexate, and corticosteroids. As you might expect, the children who, during the randomized portion, during the 6 months randomized trial, were assigned to sulfasalazine, were more likely to still be on sulfasalazine after the trial compared to those who were assigned to placebo during the study period, whereas methotrexate use and prednisone use were similar between the 2 groups. Even when you look at duration of use, if anything, this favored the placebo arm. So this is patients who were assigned to placebo versus sulfasalazine for the 6 months about 20 years ago. And the intervening 9 years, the duration of sulfasalazine, methotrexate, and prednisone was, if anything, was higher in those who were assigned to placebo as compared to those who were assigned to sulfasalazine. TNF inhibitor use is very rare. Only one child who was assigned to sulfasalazine initially ever used TNF inhibitors during this period of follow-up, which again concluded about 20 years ago, where TNF inhibitor use was less common then compared to current. Despite all that, 9 years later, the sulfasalazine group had improved status. This is the trial baseline in 1992. This is 9-year follow-up in about 2002. And despite that overall medication use was similar in these 9 years, the children who 20 years ago received, or 10 years prior had received sulfasalazine were doing better at follow-up compared to those who had received placebo during this time. So active joints favored sulfasalazine, 4 versus 2. The patient visual analog scale, this is 0 to 100, favored sulfasalazine, active joints favored sulfasalazine. The VAS favored sulfasalazine, and the percent in remission favored sulfasalazine as well. So there may be benefits to early aggressive treatment, to early treatment, but this doesn't necessarily mean you have to have early aggressive treatment based upon this study and other ones I showed you. So overview of safety in therapeutics in JAA. For the most part, the safety signals that those of you who treat adults look out for are similar to what we're looking at for in children. We have it relatively easy. Medications are generally well tolerated in children. Our patients have decreased comorbidities compared to adults, decreased polypharmacy, and decreased poor life choices. So now we speak to some of these pediatric specific safety issues. First, TNF inhibitors in cancer. I know this is discussed in adults as well. I'm going to focus exclusively on pediatric data. Is there an association between TNF inhibitor use and pediatric cancer? There was a Canadian study in 2013, published in 2013, where they reported that 6 out of 357 children treated with a TNF inhibitor from 1997 to 2013 developed malignancy. So that's a frighteningly high number. However, some Amgen post-marketing data was more reassuring than that. They found the incidence of malignancy among pediatric patients taking etanercept exceeded the population risk, 32 versus about 16 per 100,000 patient years. However, it's well known that having rheumatoid arthritis is a risk factor for malignancy. And this is true as well. I'm not going to show you the data, but this is true as well. Or I am going to show you the data. This is true as well for JIA. Sorry, wrong direction. So that is shown over here. And this is before there was a lot of TNF inhibitor uses from 2001 to 2007. There appeared to be maybe a 2-fold or 3-fold higher risk of malignancy, among patients with JAA versus the general population. Over time, this difference actually decreased, indicating that when you treat the disease appropriately, this excess malignancy risk goes away. So any study that's going to look at the risk of malignancy among patients taking TNF inhibitors has to adjust for diagnosis. A former colleague of mine at UAB, Dr. Tim Buchelman, did that in 2018. This is a claims database of nearly 90,000 children with conditions for which TNF inhibitors are used: JIA, inflammatory bowel disease, and psoriasis. He compared the incidence of malignancy among patients exposed versus those who were unexposed to TNF inhibitors, which were used in almost 16,000 or 17% of the patients. And what he found was a slightly higher incidence of malignancy among the TNF inhibitor users. This is any malignancy per 100,000 person years. And you can see for JIA and IBD, the incidence was a little bit higher. And this is especially true when you look specifically at lymphoma. However, the hazard rates for NE was 1.58, for lymphoma, this is after adjustment, 2.64. And both of these differences, the hazard rates crossed once, these were not statistically significant. So I tell patients that there may be a higher risk, but given a very low risk to begin with and a very small increased risk, there may or may not be a higher risk associated with malignancy associated with TNF inhibitors. We just can't say. The second safety issue involves JAK inhibitors. As some of you may know, that in a week or two ago, the U.S. Food and Drug Administration released a black box warning pointing to a higher risk of multiple issues, including cardiac events, malignancy, and death among patients taking JAK inhibitors for RA and rheumatoid bowel. I'm not going to speak any further to this. I'm going to keep the focus, again, specific to pediatric issues. Many of you have probably seen slides such as this, downstream targets of JAK inhibition. What I'm going to focus on is growth hormone. One of the downstream targets of JAK inhibitors is growth hormone. You can give JAK inhibition to every RA patient in the world, and you're not going to answer my question, do these impact the growth of children? Last year, the US FDA released a monograph. They said there is a theoretical risk of effects on bone development and growth with tofacitinib, which is one of the JAK inhibitors. They required additional long-term data to assess the effects of growth in this population. Specifically, they're mandating a 5-year observational study, which will go from 2020 to 2025, in which they compare the growth of children treated with JIA who were treated with tofacitinib versus children with JIA treated with other medications. So this is going to take a long time to answer. We're not going to know whether or not it impacts growth for at least another 4 or 5 years. The final safety issue is interstitial lung disease. This was a patient of mine. She was a 3-year-old girl with chronic macrophage activation syndrome since infancy. She received a variety of medications, including anakinra, cyclosporin, and corticosteroids. We had scheduled admission for bone marrow aspiration, during which time she was found to have an oxygen requirement. A CT chest showed diffuse interstitial thickening. She's far from being the only such child. In 2013, Yuki Kimura published a case series such as this. In 2019, Vivian Saper published an international case series of 61 patients with either systemic JIA or chronic MAS who then developed interstitial lung disease, as shown in some of these CT scans. Frighteningly, over half of these patients died. She identified some risk factors for ILD in this population. These included trisomy 21, an early age of onset, and a drug reaction to tocilizumab. So the question that we've been debating ever since then is it the disease or is it the treatment? Dr. Saper has argued that it may be the treatment, not the disease. Some of her evidence for this is that 46 of 61 cases have been exposed to therapies targeting interleukin-1 or interleukin-6. While systemic JIA has been recognized since 1897, ILD is new and has been increasing in frequency around the same time that we've been using inhibitors of IL-1 or IL-6. Now, however, the counterpoint to this is that, yes, we're using more IL-1 and IL-6 inhibition, but we're also using less corticosteroid usage now as compared to 20, 30, 50 years ago. So perhaps it's not these medications, but rather the decreased corticosteroid usage that is accounting for the emergence of this interstitial lung disease. Finally, Dr. Saper has argued that there's been an episode of DRESS syndrome, drug rash, eosinophilia, and systemic symptoms, and prior to the lung disease in 13 of the 61 cases. All 13 of these were on cytokine inhibitors, so she's taking this to argue that there's some immune reaction to these therapeutics that is predisposing to interstitial lung disease. However, it still is unclear and it's still a matter of debate. To summarize, JIA is a heterogeneous condition. Always consider infectious conditions and malignancies in the differential diagnosis. Early therapy may help induce and maintain lasting remission that does not necessarily require early aggressive therapy. And there's an overall reassuring safety track record of advanced therapies, although uncertainties remain on the malignancy risk with TNF inhibitors and the presence versus absence of an ILD risk in patients taking IL-1 or IL-6 inhibitors for systemic JIA. And thank you very much.
Thank you very much, Matt. That was very comprehensive and covering all aspects that may be of interest to rheumatologists. Thank you very much. I do not see any questions raised, so I think Dr. Dalia.
I do see there were,
Yeah, one question, please.
okay.
From Dr.
The first
Faiz, Professor of Rheumatology in Heliopolis University, Ancient.
Thank you, sir, for this very nice presentation. I want to ask you about in patient with sacroiliitis, child with sacroiliitis not responded to TNF. What's the next step in management?
So, to me, it depends on whether this is a partial response, in which case you can try a dose escalation or a different TNF inhibitor, or if they have no response at all. My personal opinion is that there's no reason to think that sacroiliitis in a 14, 15-year-old child is anything different than the same condition in a young adult. We know in young adults that IL-17 inhibition is highly effective, and so for these patients, I go to IL-17 inhibition if they fail the TNF inhibitor.
Thank you.
Thank you, Matt.
Thank you.
We're pleased to have you with us today. And with your excellent presentation, we come to the conclusion of our review course. And will come to the end. Thank you, Matt.
Thank you. It's great to see you.
My pleasure. الريفيو كورس خلص واعتقد الساعة 6 الافتتاح الرسمي هنا. The opening ceremony will take place here at 6 p.m. or virtual, as we know. Thank you all for attending, and I hope you all enjoyed those wonderful lectures.